G'day folks. Today we're diving into the ICU where every second counts. Here, doctors and nurses make life or death decisions, especially when facing sepsis, a condition where the body's response to infection spirals out of control. Sepsis can quickly lead to organ failure and death if not treated rapidly. The key to survival: early identification and immediate treatment, especially with antibiotics. Getting antibiotics into the patient within the first hour, what we call the golden hour, is critical. But it's not just about speed. How we deliver these antibiotics might also matter. For beta-lactam antibiotics, does a continuous infusion work better than intermittent doses? This seemingly small detail could have a big impact in the ICU. Researchers have been investigating whether changing the delivery method could improve survival or recovery. So let's explore a major study that tackled this question head-on. Welcome to the world of sepsis research. To answer these critical questions, we need big, well-designed studies, like the BLING III trial. BLING III was a massive international effort, involving ICUs across several countries, aiming to find out if continuous infusion of beta-lactam antibiotics saves more lives than intermittent dosing in sepsis patients. Sepsis is a global crisis, affecting millions and causing countless deaths each year. Beta-lactams are among the most common antibiotics used in the ICU, so optimizing their delivery could have a huge impact. Previous studies were small and inconclusive, leading to varied practices worldwide. BLING III set out to provide a clear, reliable answer. Let's break down beta-lactam antibiotics. Penicillin, Pip/Taz, Meropenem. These are the ICU workhorses, targeting a wide range of bacteria. They work by disrupting bacterial cell wall synthesis, causing the bacteria to die. Here's the key. For beta-lactams, it's not about how high the drug level gets, but how long it stays above the minimum inhibitory concentration, or MIC. This is called time-dependent killing. Intermittent dosing causes drug levels to spike and fall, sometimes dropping below the MIC. Continuous infusion keeps drug levels steady, always above the MIC. The theory? Constant exposure could kill bacteria more efficiently and improve outcomes. That's why researchers are so interested in how we give these drugs. The BLING III trial was a rigorous, randomized, controlled trial. Over 7,200 adults with sepsis in 103 ICUs across 7 countries participated. Patients were randomly assigned to receive beta-lactam antibiotics, either as a continuous infusion or as standard intermittent doses. The only difference was the method of administration, a steady drip versus periodic pushes. The primary outcome: all-cause mortality at 90 days. Secondary outcomes included clinical cure at 14 days, ICU-free days, organ support-free days, and emergence of antibiotic resistance. The trial reflected real-world practice, with clinicians choosing the specific drug and dose. Safety was closely monitored throughout. This large, diverse study was designed to give a definitive answer. So what did they find? The main result? No significant difference in 90-day mortality between continuous infusion and intermittent dosing. About 19% of patients in the continuous group and 20% in the intermittent group died. Statistically, that's a tie. Continuous infusion didn't save more lives overall, but there was a twist. Clinical cure at 14 days was higher with continuous infusion, 55% versus 50%. This suggests patients might recover from infection more effectively with continuous infusion, even if it doesn't impact long-term survival. For other outcomes, ICU-free days, organ support, resistance, there were no major differences. Importantly, both methods were equally safe. So, continuous infusion didn't improve survival, but it did boost clinical cure rates. That's a nuanced but important finding. What do these results mean for ICU teams? First, continuous infusion of beta-lactams is safe. No extra side effects or complications. But since there's no mortality benefit, switching all patients to continuous infusion isn't a game changer for survival. The improved clinical cure rate is interesting though. It might help some patients recover faster. Implementing continuous infusion requires more resources, like infusion pumps and new protocols. For some ICUs, the logistical effort may not be worth it without a clear survival benefit. But in settings where resources allow, the potential for better infection resolution could be attractive. Certain patient subgroups might benefit more, but more research is needed. Ultimately, each ICU must weigh the benefits against the practical challenges. BLING III gives us evidence to make informed choices. BLING III reminds us that how we give antibiotics matters. Even without a survival boost, continuous infusion improved clinical cure, showing that delivery details can impact patient outcomes. This trial challenges us to rethink routines and consider if standard practice is always best. Continuous infusion is a safe alternative and may help resolve infections more efficiently. In an era of rising antibiotic resistance, optimizing every dose is crucial. The results should spark discussion among ICU teams about what's best for their patients and resources. There's rarely a one-size-fits-all answer in medicine. The details matter. Let's keep refining our approach to give every patient the best shot at recovery.